Hi, this is Dr. Bhargava, and in this short video, I have several interesting cases to share with you. Our first patient had a HIDA scan, and they had prior partial right hepatectomy, and the question was bile leak. So let's take a look at this dynamic acquisition. So the liver takes up the tracer. We can see that part of the right lobe of the liver is missing, and the liver concentrates and excretes the tracer into the biliary tract, but then there is a focus that goes towards the right side and accumulates there, and maybe there is some faint activity linearly extending superiorly. So we acquired more images. Let me show you this dynamic acquisition one more time. Here it starts to play again. All right, so there is a post-surgical bile leak, but on the single frontal image, we cannot localize where it is, anterior to the liver or posterior to the liver. So we acquired more images. This is the spot view in the anterior projection, and we see the same finding that we saw on the dynamic acquisition. Liver has excreted the radiopharmaceutical, there is activity in the small bowel, and this is the focus of bile leak, and there is probably some activity extending superiorly. On the lateral view, we find that here is the liver, and this corresponds to the liver that we see on the sagittal reconstruction of this patient CT. There are these post-surgical changes from prior partial right hepatectomy, and this is where the leaked bile has accumulated posterior to the liver, and we see fluid right here, and this is bile, and we see some activity extending superiorly, and so it's crossing the diaphragm and it is going up into the chest. So this patient had a post-surgical bile leak that was identified by the HIDA scan, and it was then further evaluated. Here is a good article on this topic, and the authors say that familiarity with the expected post-operative appearance on HIDA scan and correlation with SPECT-CT or other imaging modalities when available are very important. Here's our next patient. This patient underwent an FDG PET-CT scan for AML, acute myeloid leukemia. We knew at that time that they also had bladder cancer, because before the FDG PET-CT, they presented with a CT urogram. And so in CT urogram, we acquire a CT without contrast, which is right here. And this CT shows that there is a mass arising from the left posterolateral wall of the urinary bladder. And in a frond-like pattern, this extends into the urinary bladder cavity and has some small calcifications at the surface. On the delayed image after contrast, when the kidneys have excreted the contrast into the bladder, we find that the mass is better seen. It is, like I said earlier, frond-like and growing into the lumen. This is classic of a urothelial bladder cancer. And this is now a filling defect seen inside the urinary bladder arising from the left posterior wall. So we know that this patient had urinary bladder cancer. And so with that background, let's take a look at their whole body rotating image from FDG PET. And we know that FDG is excreted from the kidneys into the bladder. And that's exactly what we see here on this rotating image. There are other findings also, which I will not go into, because the teaching point that I want to make here is that when we look at the CT and the fused PET-CT images from this FDG PET-CT scan, we find that there is urinary bladder wall thickening. We see the tumor, but on the PET image, we cannot evaluate focal hypermetabolism in the tumor because it is surrounded by excreted FDG in the urine, which is in the urinary bladder. So FDG PET-CT is limited in the evaluation of primary urinary bladder cancers, and these authors have shown that it has a role in staging of lymph nodes and to evaluate for extrapelvic metastasis. This is our next patient, and they underwent a FDG PET-CT scan for whole body staging of their head and neck squamous cell cancer. Let's start by looking at their rotating image. So they have no FDG avid metastatic disease below the neck in their chest, abdomen, and pelvis. And on this fused PET-CT image at the level of the left tonsil, we find that that's their primary, and they have bilateral hypermetabolic lymphadenopathy in both sides of the neck. And at the level of the dome of the liver, we find that there are no focal lesions. They also, around the same time that they were diagnosed with head and neck cancer, had a CT of the abdomen and pelvis, which showed a lesion in the liver that was evaluated with multiphasic CT. And so on the non-contrast enhanced phase, we find that the tumor at the dome of the liver is iso-intense. On the arterial phase, you can see here the aorta is opacified. The tumor shows uniform arterial phase contrast enhancement. And in the delayed phase, it shows washout and a peripheral pseudocapsule. So these findings suggest that this is a hepatocellular cancer, or HCC, and we use the LIRADS criteria to evaluate these lesions. So based on the size, this would be an LR5 lesion, and so no biopsy is needed in this patient. This would be HCC until proven otherwise. And so the interesting point of this study, the PET-CT scan, is that there is no focal hypermetabolism seen in this primary HCC in the liver. And we know that this is a limitation of FDG PET. And here is an article on that topic where the authors say that FDG PET may have a role in evaluating regional metastatic lymph nodes and also extrahepatic metastatic lesions. And FDG PET, when used as a separate imaging modality, is insufficient for the diagnosis of primary HCC lesions. Thank you for watching.